Here in the Senate, and thanks everybody for being patient. We've had to push the timing back relating to the session going on a little bit longer than we anticipated. So, Chairman Hodges, would you mind opening us up in prayer number 11?
Would you join me in prayer, please? Gracious God, thank you for this beautiful day. Thank you for all the many blessings you've bestowed upon us. Thank you for the opportunity to represent the people of the state of Georgia and lead us and guide us in all we do. Grant us the wisdom to make the right decisions. And in your name we pray. Amen.
Thank you, Senator. Appreciate that. We have one bill today. The intention was not to catch us up for the rest of the day, but I think this will. I don't think this is going to be controversial, but we do have two people to testify. I got Chairman Huffstetler to present Senate Bill 195, and we have a quorum. And Chairman Huffstetler, the floor is yours. You're on number two.
Number two, correct. Thank you, Mr. Chairman. And great to be here and everybody here for this bill, which I think won't be too hard of a bill today. It deals with HIV, pre-exposure prophylaxis and post-exposure prophylaxis. And part of the reason for this is the Atlanta area and this metro area has some would say the third highest rate in the country or the fourth highest rate, depending on whose statistics you look at. But we're certainly,
Chairman, would you mind pulling that?
We're
mic
certainly
up
way up there in that category, and it can cost $30,000 to $60,000, $70,000 to treat in a year, maybe $400,000 over a lifetime. And the pre-exposure medicine alone is, I had numbers of about $60 a month for generic, and I found out that there's some generic for $23 out there. So the difference in cost is significant if we can prevent it, and also the quality of life as well. So getting into the bill a little bit, what this allows is that the pharmacists who we've given vaccines and different things to prescribe would allow them to do this medicine. And there are some injectables I'll talk about a little bit later, very similar to the vaccines, that it also allows. But on the third page, you'll see that they have to go through a training program. They've got to have this ready by January 1st. And I should back up and say that the Department of Public Health had a lot of input on this bill, as well as some others, and made some changes that I had agreed to on it as well. This training also includes some financial assistance programs, because there are some programs out there to help educate people, and also to let them know the physicians, the health homes, those kind of things that they can be available for. So if they go through this training, a pharmacist can dispense a 30-day supply up to a 60-day supply, and also administer a long-acting injectable of pre-exposure prophylaxis if they meet the requirements that they need there. And of course, they have to know the contraindications to this medicine, have to be trained up in that. And when we get into the injectable part, you'll see that there has to be a physician protocol agreement that they have with the physician, same as for the vaccines. So moving on to page 4, it again says, it says 28 days a month, basically, supply that they can do. And they're supposed to notify their primary care physician, though in some cases we realize they're not going to have a primary care physician, in which case they'll notify them of who's available to do that. Just trying to hit the highlights here, and then we can go through it more if we need to. But page 6 is where our protocol agreement is there for the injectables. It says a physician has to be in active practice of medicine and can prescribe it, and they have to be available for immediate consultation, and if not available, another method of consultation if they need it. If you go on to page 7, lines 163 to 165, In no event shall a pharmacist administer this while they're remaining in their vehicle. I don't know why you have to put this in, but I guess you do because somebody might try to do drive-by medicine. But anyway, it's in there to make sure everyone knows we don't do that. And again, I'm be glad to get into the weeds of this bill if we need to. But if you go on to page 11, it does set up some fines there for a pharmacist if they don't have a protocol agreement, and some penalties, first, second, and third violations if they're doing this. So we're similar as we've done with a lot of medicines. We're letting them prescribe this medicine directly to the patient, only if they've had a training program, only if they've, done the exam of, questions such as, do you have severe liver or kidney disease? Are you pregnant or breastfeeding? There's a few things you don't want someone taking for this. But if they have that agreement in place, they're allowed to prescribe it 30 days up to 60 days. And see if there's anything else. That's probably the highlights, but if there's any questions on the bill, I'll be glad to answer them.
I just want you to also note there is a letter and testimony from the policy director from Washington relating to this in your folder. Any questions from the committee? Senator Mangum, you're on, is that 6? Yes. Okay.
I want to applaud this bill, number one, and I support it, and I'm surprised that I'm not a co-sponsor. But I find it quite alarming to me that the last sentence on this letter, one of the key challenges in curbing the spread of HIV is that for every 100 people with HIV, only 87 know their HIV status. Is that accurate, or what can we do about that? Only 87?
Well, we can encourage everybody to see healthcare providers, but there's going to be some people that may have it for a while, and actually the cost of it goes up the longer
They don't know.
they don't know it. There's something called CD4 count, which would be your white blood cell count, and the higher that the lower that is actually is what it is, then the more it costs to treat it, and the longer it progresses, the lower that count goes. So it's actually also more expensive to treat if they haven't been diagnosed. So the aim is to have pharmacists talking to people that maybe don't see their physician and say, hey, are you aware of this? Is this something that category you might fit into? It's not a magic bullet, but I think it can lower the rate here in the metro Atlanta area and the rest of the state.
Any other questions? Senator Kirkpatrick, you're on number 10.
I guess my question's about the liability insurance. That's one of my questions, and that is that pretty standard for pharmacists to carry that are independent pharmacies, do you know?
It's on line 174, is that
Yeah.
right?
I think they've all, as the rest of us, have to have liability insurance. And I think it's part of, what they do in their job, they have it. So I believe that's fairly standard.
I don't know the number with that, but I think we may get some answers maybe from the testimony.
Yeah, and then just the only other thing is, it looks like in most of the bill, it says it's the pharmacist that does the injection. But then on line 208 or 209, am I reading that to say that a pharmacy intern or a pharmacy technician could also do it?
I think it's the same qualifications for the vaccine, but I think they've got to have training in it to do it. Now they're not doing the the initial exam of it. They're just the one giving the shot. Now I know we have a lot of people that give shots in hospitals aren't necessarily the one that is doing the diagnosis of it.
Okay, thank you.
All right, we have two people that signed up to testify, Cindy Shepard and Kathleen T. Hine. Thank you.
Mr. Chairman and members of the committee, thank you. I represent the Georgia Pharmacy Association, and so, Senator Kirkpatrick, to your question, the independent pharmacies do carry the liability insurance, and I'm not exactly sure of that number, but this was vetted by our board, and we totally support this bill 100%. Any other questions?
Any questions from the committee for the Pharmacy Association? Ms. Shepherd?
Thank you.
If not, thank you. Kathleen? She supports it, Georgia AIDS Coalition. And anybody else from the public? No? And any questions for the author? Number 9.
Thank you, Mr. Chair.
Sonora?
Yeah, thanks for bringing the bill and the good supportive letter. Isn't it true that what we do with this proactive approach means that people with infection can manage it and work, be on a payroll and be paying taxes as opposed to declining in a worsening condition, leading to that, as well as, thank goodness, not even getting the infection.
Right, they say an ounce of prevention, it talks about a pound of cure, that's only 1 to 16. In this case, it's $23 to 30 to 60,000, so I think it's more than an ounce to a pound in this case that it will save us.
You're right, let's be clear. So we're not treating HIV infection, we're preventing HIV infection. It's either pre-exposure or post-exposure. So it's example, in the hospitals, someone sticks themselves with a needle, you may take post-exposure prophylaxis may take these drugs to prevent you getting infected until you know the results of that patient's blood, whether they're HIV positive or not. And the pre-exposure, if you're going to put yourself at potential risk, then this would reduce your risk of getting HIV infection.
And I've been in the operating room 2 or 3 times with somebody who did have to go have that done because of a needle jab or something from an infected
Yeah,
person.
unfortunately, that does happen in surgeries and in offices too. Unfortunately, it is a risk. Any other questions or concerns or thoughts? If not, we'll have the will of the committee. Have a motion. Senator Mangum. Do pass. Second, Chairman Brass. Any further discussion? All those in favor say aye. Aye. All those opposed, like sign. Pass unanimously. Thank you, Chairman Huffstetler, for bringing it.
Thank you, Chairman Watson.
Appreciate that. We do have a meeting on Wednesday, but right now we're still in the deciding process whether we'll actually have one or not. We'll let you know in advance. Thank you.